Good to see everyone here. It's always good to have people engaged in the work that we're doing, and the work that's so important to people with intellectual and developmental disabilities. Um, Welcome to our Protecting Medicaid and HCBS, Preventing Coverage Loss Under Work Requirements. Um, so with today's webinar, well, let me tell you first a little bit about NACDD. NACDD represents the 56 states and territories, territorial councils on developmental disabilities. And we support councils, developmental disability councils, in advancing self-determination, inclusion, and community living for people with developmental disabilities. If you don't know what a DD council is, I'll tell you that too. So every governor of every state and territory um, appoints people to be on a developmental disability council. And that council does all kinds of work in their state or territory. They provide guidance to the governor. They work at their state houses. They educate people with intellectual and developmental disabilities in their support circles. They fund a lot of grants. The real hard work is done by DD councils. And at NACDD, the National Association of Developmental Disability Councils, we help all the councils get their work done. We represent them at the federal level. We just ensure their success so that we can see people with intellectual and developmental disabilities live their best lives. That's what NACDD is about, and that's what our developmental disability councils are about. So this is our second webinar on challenges from HR 1, which cuts Medicaid through work requirements and other restrictions. Um, HR 1, some people also called it the big beautiful bill. So you might have heard about that. The changes from HR 1 put people with disabilities at risk of losing coverage, um, limiting home and community-based services and they increase the risk of institutionalization. It could undermine decades of progress under the ADA and Olmstead. So we're concerned. So today we want to focus on education, information, and solutions. So we're joined by Jalila Selassie. I'm sorry if I pronounce your name wrong. I'm trying real hard, from Justice and Aging, who will show us how their toolkit that they've created can help advocates at the state and local levels prevent coverage loss and protect HCBS. NACDD will be developing a toolkit with Justice in Aging's toolkit as a foundation. They've asked us to do that, on our own, so we're happy to do that, and you can look for that to come out in a week or two. It's really critical for aging and disability advocates to work together on everything, right? At your local levels, at your state level, at the federal level. And so on this particular issue, the issue of Medicaid work requirements, I'm wondering how we're all going to work together. And this is part of this education information is about working together. And that's what this toolkit can help us do. But what I'd like to do is I'd like to stop here for a second and read the room and get an idea of the people in this room here, how much folks in this room know about Medicaid work requirements. So we could kind of have an idea where everyone's at. So we're going to put up a survey real quick, real simple questions to answer. So the survey says, how many of you in the webinar today are familiar with Medicaid work requirements? Very familiar, somewhat familiar, not familiar at all. So if you can answer those questions, it'll help us get an idea of how many, how familiar people are. I'm going to say maybe I'm somewhat familiar. I'm going to say somewhat. Okay. It says that somebody says they can't select an answer in the survey. Any idea why that would be? Put it in. Can you please put in the chat if you're able to answer? Okay, it's working now. Great. The survey's working. So y'all go ahead and do that survey and I'll move on. So, evidence shows most people lose coverage, Medicaid coverage, because of paperwork, right? You lose your Medicaid coverage because you forget it's time for you to do all that stuff again, right? Or because you're required to send in a whole bunch of forms and by certain deadlines or whatever. It can be complicated. So, and it's not because people are not working or they don't need the benefits, it's because it can be confusing and bureaucratic. So, for example, nearly 18,000 people lost Medicaid in one state, even though most were eligible, and most of them said it was because of paperwork. Medicaid cuts also weaken home and community-based services and the workforce, increase institutionalization risk. By working together, aging and disability advocates can protect coverage, strengthen home and community-based services, and help states support people living safely in their communities. So some quick housekeeping tips. We always have to do that stuff. This webinar is being recorded. If you have questions to submit, as Eric said, please put them in the Q&A section. If you put them in chat, chances of us missing them are high. If you have a problem during this, you can put it in the chat and at Eric Berg so that he sees it and he'll try to fix whatever and he'll respond in the chat. Live captions are enabled. So down at the bottom of your screen, you see a little CC. It says show captions. You can either put the captions at the bottom of your screen or on the right. And if you put it on the right, you'll be able to see all the whole conversation that's gone on. And those are all the housekeeping tips. Again, thank you all for being here. I love that so many folks are here. Oh, it looks like we've got our quiz results up. 61% are somewhat familiar, like me. That's what I am. Very familiar, 28%. Who are the experts in the room? Jalila, for sure. We've got some experts for sure. Not familiar at all, 11%. Okay, great. Well, let's get started. I'm going to go and turn it over to Jalila, and if you can bring up the slides, Eric, that would be great. Thank you.
Thank you so much. And actually, I have the slides, so I'll try to make sure I can pull it up real quick. Okay. All right. Can everybody see that all right?
Yep.
Looks like it's coming through just fine.
Okay, perfect. Let me make sure I put it in presenter mode. Perfect. That looks okay?
Looks
Excellent.
perfect.
It's always hit or miss with me with technology. So glad the Zoom gods are with us today. Hi, everyone. It's such a pleasure to be here today. I'm Galila Selassie with Justice and Aging. Very happy to be here. I do a lot of work with NACDD, and we really, really enjoy our partnership. And I'm very thrilled to be here to discuss the work we've been doing around the Medicaid work requirements. Just a little tidbit about Justice and Aging. We're a national organization that uses the power of law to fight senior poverty. And we do it through access, through our litigation, through making sure we have affordable health care, economic security like Social Security and housing, as well as elder rights. And we've been doing that since 1972, making sure that we also focus on groups that are historically marginalized. And so I want to give a quick overview for what Medicaid is, why Medicaid is so important. I'm sure folks know this. We've either in our work or in our personal lives or in the lives of people we love, we've seen how Medicaid is really crucial. But with that said, I think some of these numbers really help highlight the important role of Medicaid. More than 7 million seniors and 10 million people with disabilities rely on Medicaid. And it's also really critical for people who are duly eligible for Medicare and Medicaid. 12 million people with Medicare need Medicaid to make their Medicare affordable. Otherwise, they're unable to use their Medicare services because they can't pay for the out-of-pocket costs or the copays or the premiums, and that's where Medicaid really kicks in. Millions more older adults and people with disabilities are insured through Medicaid expansion. And that's something that a lot of policymakers and a lot of members of the public aren't aware of. Even though there are disability pathways where you can get Medicaid specifically for disability, they can be incredibly restrictive. They can have really, really low income limits, really limited assets. The process to get it can take years, can be really burdensome. For that reason, you have a lot of people with disabilities who get Medicaid through the ACA Medicaid expansion because it doesn't require all that paperwork to sort of prove your disability. And it's much simpler in terms of determining your income eligibility than some of the disability pathways are. So there are 5 million aging adults age 50 to 64 enrolled in expansion. And among Medicaid enrollees under 65, 1 in 5 use nursing facility care, and 1 in 10 use HCBS through expansion. So again, there's this misnomer that there's these really clean buckets of Medicaid enrollment, and people with disabilities are here, seniors are here, children are here, so on and so forth. And for the adult population, it is much more mixed because of how complicated each Medicaid program and the eligibility categories are. And then Medicaid isn't just like traditional health insurance. It's very, very broad and covers more than just traditional medical services. So as you mentioned, home and community-based services or nursing facilities, Medicaid is pretty much the only game in town when it comes to covering long-term care. Medicare is incredibly limited in terms of duration and the process. And private insurance is really unaffordable and unattainable for many. And of course, as is private pay. So that's really critical there, is most people aren't aware that Medicare isn't the primary payer of long-term care, it's Medicaid. It also covers non-emergency medical transportation, which is really critical, especially for aging and disabled populations who are unable to drive themselves to their medical appointments, who need safe, accessible transportation. Because what good is having healthcare if you can't actually get to those healthcare services, right? And so that's a really critical part of it. And then, as I mentioned, financial assistance to make Medicare more affordable for those who are duly enrolled. So now I'm going to focus on HR1, just sort of a quick overview on that, and some of the impacts on older adults and people with disabilities. One big thing that HR1 does is it does cut Medicaid funding through provider taxes, which is sort of how states help. States have a way of taxing providers and then using those taxes to get reimbursed by the federal government in a way. And so it's a little bit complicated, but there's a provision in there that has been altered through HR1 that basically limits how states can do that. So it is effectively cutting their ability to fund Medicaid from the federal government, which means that's more cost instead of coming from the feds, is coming from the states. As we know, states always have to have a balanced budget. And so it's going to force them to make some really difficult decisions about what to cover, what services to cover in healthcare and education, and so on and so forth. They may also be cutting provider reimbursements. We've been seeing so far a couple of states have already announced that they're cutting provider payments. And we know that providers are not getting rich off Medicaid as it is already. So that limits networks and availability and could potentially worsening their direct care workforce crisis that we're experiencing. It's increasing barriers to accessing Medicaid coverage. The big one that we're talking about today is through work requirements. There's also increased redetermination process, co-pays being included, and a few other things like that are basically making it harder to maintain your Medicaid coverage through additional paperwork and other barriers like that. And then there's been some really significant impacts on access to both Medicaid, Medicare, and marketplace tax credits for lawful immigrants. So people who are here legally, lawfully, paying taxes, doing everything. There's much greater restrictions on that. I could talk about these things for days. So again, we're going to focus on Medicaid work requirements. And then the slide, we have a resource with really detailed descriptions of all of the provisions of HR1 that you're more than welcome to look into. I'm not going to spend too much time on this, but this just goes into the details about how the cuts to federal Medicaid funding is happening through, like I said, that reduced spending from how states use their provider taxes to get reimbursed. There's also a provision in HR1 that reduces some of the emergency Medicaid services for some people who are ineligible for Medicaid due to their immigration statuses. And then with these things, they're mostly targeting the expansion states because expansion has a very high federal match. And what that does is that penalizes states for being expansion states. For the 10 or 11 states who have not expanded Medicaid yet, it disincentivizes them. And then it's going to reduce the number of people in those expansion states who are enrolled in Medicaid. And again, this is a problem because we've seen that millions of people with disabilities, including developmental disabilities, are getting Medicaid through expansion. So this idea that these cuts aren't actually hurting people with disabilities is just not true. It definitely is. Another interesting tidbit I heard is that people with disabilities and older adults make about 20% of Medicaid dollars. or excuse me, to make up 20% of Medicaid enrollees, but more than 50% of Medicaid dollars are going to the age and disabled populations. So there's just no way to make those cuts without having an impact when these two groups make up a significant chunk of that spending. And then, as we said, 86% of optional Medicaid spending supports older adults and people with disabilities, particularly for Medicaid HCBS, which accounts for 51% of all optional spending and 32% of all Medicaid spending. And the reason why that's really concerning is that we saw during the Great Recession, where cuts were made around between 10 to 20% for various Medicaid programs, Medicaid HCBS programs, that the reductions of services were significant. And it led to significantly longer wait times. Every state made cuts to the HCBS programs during the Great Recession when funding was cut, even though nothing from the Great Recession directly targeted states' HCBS funding. But it was the natural thing on the chopping block because states have that discretion in how much they fund it. So we're seeing that the cuts in HR 1 are pretty identical to the ones during the Great Recession, and we're very, very likely to see some degree of cuts, probably greater than what we saw in 2008, 2009. So now going into work requirements. So the law now mandates that every state implement work requirements for most adults ages 19 to 64. And what that means is that they have to complete at least 80 hours of qualifying activities per month. So that means working, like paid work, getting an education, volunteering, or participating in a job training program. We're supposed to be we've gotten some guidance from CMS that hasn't been very helpful. CMS being the Centers for Medicaid and Medicare Services. We're supposed to be getting more that define some of these things more clearly, like what is an education program, what does volunteering look like, things like that. So I don't have much for you yet, but this is what the statute does allow to be considered as a qualifying activity for purposes of meeting the work requirement compliance. And then people have to provide proof that they're complying with work requirements at least 1 month prior to enrolling, and then prior to their eligibility redeterminations every 6 months. That means that before if I'm signing up for Medicaid in February, I have to show that I was working in January. Or if I'm renewing my coverage in February, I'm going to have to show that I've been working for this prior months when I'm up for my redeterminations or my renewals, which has now been moved from 1 year to 6 months for the Medicaid expansion population. So that's putting, again, a lot more work on the beneficiary to have to submit all this paperwork before they can even begin getting their Medicaid. And then a really, really cruel part of work requirement of this language is a lockout provision, where somebody who is subject to Medicaid work requirements, but isn't meeting those requirements and isn't eligible for an exemption or isn't receiving an exemption, they also cannot receive marketplace subsidies. So it would be where somebody who might be between 100 and 138% of the federal poverty level, if for whatever reason they can't get their Medicaid expansion, at least they could get marketplace subsidies. Well, now they can't. They can't get those tax credits because now they're going to be considered as being almost voluntarily incompliant, as opposed to not meeting these very, very restrictive standards. So that's really problematic, and that's what's going to significantly increase the number of uninsured people we have. This chart is from a informational bulletin, some guidance CMS put out last month. I will say the guidance isn't terribly helpful, but this does illustrate how states can implement these Medicaid work requirements early. So the statute requires it to be implemented by January 1st, 2027. We've heard from Nebraska and probably a few other states that they want to implement it early, which is really concerning because this is a lot to put on states and caseworkers and everything like that, as well as the beneficiary outreach. However, it does show that if states whether they do it by December or they do it earlier, they must engage in beneficiary outreach up to at least 1 month, but if they're doing it in January 1st, but at least 3 months prior to whatever date that they do begin their community engagement. So you can see here for number 3, if a state wants to implement it in October, then they have to begin outreach to inform beneficiaries of the upcoming changes and how they can submit proof of exemptions or proof of their compliance by July 2026. So I do find this chart helpful in that way if your state is considering that. And then the link to the bulletin is here in the slides. Now, some Medicaid groups are excluded from work requirements. So the people who are really subject to work requirements are people in the Medicaid expansion program or a couple of states that don't have it's not quite Medicaid expansion, but it's expansion-like. So that would be the Georgia Medicaid Pathways Coverage Program. And I believe it's Wisconsin also has a similar Medicaid expansion program, but it's not exactly Medicaid expansion. They're doing it through a waiver. And so that's what this is targeting. There are populations that are not at all subject to these. So it's not so much an exemption. It's like they should be completely excluded from even being considered in the category of people who are subject to work requirements. So I'd be people who are eligible for Medicare, including those who are duly eligible, people who are under 19 or over 65, people who are receiving Medicaid for pregnancy or postpartum coverage, and anyone receiving Medicaid under an age, blind, or disabled pathway. So I make those categorical distinctions because the statute's wording is really terrible here. Those are categories of people who are excluded. On top of those categorical exclusions, there are individuals within the expansion population who are exempt. So these are the people who have to submit some kind of paperwork, check a box, provide documentation or whatever to show why they're not meeting the work requirements and why they're exempt. There's a few different categories. I'll go through them, but the 2 biggest ones we've been focusing on is the quote medically frail, which is terrible language, but that's what the statute says. And under the medically frail exemption, that includes people who are blind or disabled under the SSA rules, which means, you're unable to meet substantial gainful work activity because of a disability or you have a certain level of vision loss. If you have a substance use disorder, disabling mental condition, a physical, intellectual, or developmental disability impacting at least one of your activities of daily living, or a serious or complex medical condition. Again, these are all pretty vague, pretty broad terms. So this is where guidance from CMS would be really great, or if we can sort of, what we've been trying to do with our toolkit that we'll get to in a minute, and what we were trying to encourage advocates to do is think about what are the ways that people can show that they're medically frail under these programs easily. What we've been hearing from lawmakers time and time again who supported HR 1 is they don't want people with disabilities to fall through the cracks. They're supposed to allegedly try to keep the Medicaid program for them. And so what we don't want is when these 6 bullet points, 5 bullet points seem great, but if to show a serious or complex medical condition, you're going to need 25 pages of paperwork and 3 doctor signatures and so on and so forth, well, that's not going to be very accessible or very easy. And you're going to guarantee to have a lot of people who should meet this exemption fall through the cracks and lose coverage. So this is where the language of the statute might seem broad, but it's all about the application, as we'll get to as we talk about the toolkit and some of the next steps for advocates. And then the other big category we're focusing on is caregivers. So it includes exempted people are parents of dependent children who are under 13. Don't ask me why a parent with a 12-year-old deserves health insurance, but a parent of a 14-year-old doesn't. I don't know why, but that's what Congress said. And then caregivers of a disabled individual, which actually includes an older adult. The exact language under the caregiver exemption says the disabled individual, but it also defines caregiver using the Raised Family Caregiver Act, which I'll get to in a second. And that definition includes older adults or anybody with a functional impairment. So again, as we talk to sort of what our advocacy actions are, That's one thing that's really important, because a lot of aging adults might not consider themselves disabled. They might be having some mobility issues, maybe some cognitive issues, or things like that, but it's not necessarily associated with a specific disability, a specific condition. So again, it's really important that the caregivers of parents and grandparents and aunts and uncles meet this exemption, and that it's not interpreted so strictly. There are another additional exemptions that are a little bit more specific, so I don't want to get to them in too much detail. Again, we don't have much guidance yet from these, but that's youths in foster care or former foster care youths, and the people receiving Indian health services, disabled veterans, people who are already meeting work requirements under the food stamps program or temporary aid for needy families, incarcerated or recently incarcerated individuals. And then there are a couple short-term hardships that states can provide if you're in like a federal disaster zone after like a natural disaster, for example, if you've been institutionalized, or if you're experiencing, your area is experiencing very, very high unemployment. So why are work requirements so bad? As you can probably tell, I'm not a fan of it, and most people who work in this space aren't. The reason is that most people on Medicaid under age 65 are actually working, or they meet one of the exemptions. KFF did a study on this that I've linked to here, and about 65% of people on Medicaid under 65 are working. And then for the other, 37%, they're either disabled, and this is part of the expansion population. So that other 37% that isn't working is either disabled or taking care of a family member or in school. So we're creating a very massive burden on millions of Medicaid enrollees for a chance that this 8% might not be, try to go after this 8% of people. And even among those 8%, the reason why they aren't working hasn't been stated very clearly. Some people have retired early, but it's actually due to a disability or a medical condition. And so one thing that's really concerning is that work requirements we've seen historically when Arkansas implemented it briefly and when Georgia began implementing their work requirements, it kicks people off. That's how the states get their savings. Again, most people, if it was done exactly right, most people wouldn't be losing their coverage because most people are already complying with work requirements or an exemption. The way the states get people kicked off and get their savings is by being overly restrictive with their exemptions, or by creating very difficult administrative barriers like technical issues with reporting. We've heard Dr. Oz talk about putting out a website or an app for people to show like they're disabled or report their hours, which can be very inaccessible for many, many reasons. And so that's the problem here is it's never worked before. It's never improved employment rates. Oftentimes people have lost their jobs because of Medicaid work requirements because they weren't able to get healthcare that helps them be healthy enough to keep their jobs. And it's really, really fraught with significant burdens for both the state and the individual. So I'm not going to go through all of this, but this is just one example. I used to practice in a state that was a non-expansion state. And so this is the experience of somebody who has to prove they need healthcare, to prove why they need healthcare in order to get healthcare. So this is an individual who, in a state that didn't expand Medicaid, had to submit, but has significant disabilities due to diabetes, had to go to the doctor, but doesn't have insurance, had to pay out of pocket and on like a sliding scale, but couldn't afford it, stopped going to the doctor, stopped going to get his prescription medications that was paying out of pocket. At the same time, the state said, well, if you want Medicaid because of your disability, well, you have to go to your doctor and you have to get his or her forms and things done and whatever else. As a result, because their healthcare, they couldn't get healthcare through Medicaid, they had to cut back their hours. They ended up having irreversible vision loss because their diabetes became so uncontrolled. And then eventually they did get disability benefits, but it got to a point where it was really, really dangerous. And this is exactly what I anticipate us seeing where you have to prove your disability in order to get Medicaid by proving your disability for an exemption. And what does that process look like? If we make it where you have to go to the doctor to do X, Y, or Z, get all these forms, get all these things, then it's very, very likely you'll lose your coverage. And of course, your health conditions are only going to get worse if they are not taken care of properly. So a couple challenges with work requirements. One thing that we've been seeing, and this is based off of the states that are already trying to get things together to implement work requirements. And so I've been seeing in some of their like draft forms and some of their policy points is that there's a lot of confusion over the populations that are excluded, like the people from the age blind disabled program versus those who are individually exempt, like the caregivers or the medically frail. And it's really important that those categorical Medicaid populations aren't put in a position where they have to submit forms or they have added burdens to. It's going to be bad enough for the expansion population. We don't need to expand the burden to other groups who are categorically exempt in the statute. So that's one big problem. As I mentioned, another big problem is states interpreting exemptions very narrowly. So we've seen where states are defaulting under that medically frail category. There were 5 or 6 different definitions for medically frail. We've seen states defaulting to that first one, that SSA definition, because that's what they know. Oh, you're disabled because you can't work, so you have to prove to us you can't work. That's not it. If that was Congress's intent, that would have been the only thing under medically frail, but it's not. They have all those other serious or complex medical conditions, a disability impacting your ability to engage in activities of daily living, substance use disorder, what have you. They have all these things. So it's really important that states don't interpret it overly restrictive. And then relatedly, this idea that as someone who is disabled must have a specific diagnosis for their caregiver to receive the exemption. There's a direct reference to the Raised Family Caregiver Act that does not require a diagnosis of particular kinds. It's just, as somebody who has an impairment or needs an assistance that the caregiver is providing them. So that's, again, very often aging adults who might not have a specific condition or might have multiple relatively minor conditions that together have a big impact on their functional impairment that they require a caregiver. That caregiver shouldn't be losing coverage. And then another big thing, because again, our policymakers aren't always aware of how people actually live their lives, is that some people can be, I should say before that, one big problem too is that the statute gives states a lot of flexibility for how frequently they report the Medicaid work requirements. So it could be done monthly. Every month they have to go through and submit these exemptions, submit their hours and all that, which again, we saw in Arkansas for the brief period they had it and was an absolute disaster. Or they could be on the more generous side and implement every 6 months at their renewal periods. So we're really concerned about which avenue states will take. I'll also say that the monthly reporting hurts everybody because the more that Medicaid workers and caseworkers have to go through this burdensome process of looking through their compliance records for Medicaid work requirements, that takes them away from helping other Medicaid groups who have questions about their Medicaid, who need help completing their applications, processing their applications. We saw in Georgia when they implemented their work requirements, somebody who's receiving Medicaid under the age blind disabled waiver, usually it takes about 45 days for it to be approved, ended up taking almost 6 months because so much energy was going through to work requirements that somebody not at all affiliated or required to submit work requirements ended up suffering because of that. States are also supposed to use ex parte data, which means they use existing data without having to contact the beneficiary. So for example, if there's any payroll data that shows they're in compliance, they can use that to minimize the paperwork on the individual. And that is great. Or if they're receiving benefits through the VA that shows they're exempt or anything like that, that's great. The problem is that sometimes that ex parte data might be used as proof that they don't meet an exemption. So for example, there may be payroll data that somebody with a disability is working, but they meet that medically frail definition. So the state doesn't need to make them submit their hours, right? Some people with disabilities are working because it's accommodating, they can do it, it's whatever. So we don't want to get into the like Social Security disability world where we're saying by working, you clearly don't meet this exemption, because that's not what the law says. You can work and still meet an exemption. And again, if you've lived in the Social Security space, it seems counterintuitive, but that is what Congress intended. And the goal is to is to keep people working or get people working. Why would you punish somebody who is working and has that data available to them by failing to let them meet the exemption? So it's really important that even if there is payroll data or evidence that people are working, that they are evaluated for the medically frail exemption, and that payroll data isn't used against them. Same for caregivers. There's nothing in the statute that says you're caregiving, you're only considered an exempt caregiver if you're not working. Some caregivers may be able to work, even though they meet that caregiving exemption, if they have really reasonable employers or flexible hours. They shouldn't be punished because they have wonderful employers, basically. And then the other big concern is only relying on that ex parte claims data. So we're seeing states that say, well, if you have a caregiver through Medicaid and the state is paying for your caregiver, family caregiver services, then that's the exemption, the end, case closed. Obviously not. There are many, many family caregivers who are caregiving more informally. And so it wouldn't be appropriate to just require this one avenue as proof of their caregiving status. And so I do really want to get to Q&A. So I'll get through this really quickly. Some recommendations that we have in our toolkit is that making sure that, again, those non-expansion populations not at all subject to work requirements are automatically excluded. We don't need them to do that individual paperwork. Not imposing additional restrictions that makes it harder for people to, makes it easier for people to fall through the cracks, even though they are actually exempt. Making sure that raised family caregiving language is applied to include older adults. Really easing the administrative burden. So making sure that there's like really good screening questions that are very clear so people aren't confused by what questions the state is asking. That's very accessible and easy to understand. Ex parte verifications, as I said, and then the use of self-declaration so that, for example, caregivers don't have to figure out how to prove that they're caregiving. That's something that they can attest to. That would be much, much easier on the individual as well as the state. And then, as always, there has to be accessibility, due process, and operational safeguards. People are going to have questions. People are going to need assistance. They may lose their coverage improperly, and they have to have fair hearing and notice rights, and making sure that the state has all that in place. So now this infamous toolkit that I keep referencing, we are regularly updating this toolkit that's available here on our link and then on the resource slides at the end, where we give an overview of the work requirements and then some of these principles I've touched on about what the law actually says and why we need to make sure that states aren't misinterpreting that, or even the federal government isn't misinterpreting that as they put out guidance. And then critically, we also have a template letter that advocates can use and customize it and alter it and share with your state Medicaid officials. Here's a look at a screen grab of that template letter that's on the same website as the toolkit. And you're welcome to use this, send it to policymakers, send it to your state Medicaid officials, anybody else, either as an individual or as part of an organization, to make sure that there's pressure on your Medicaid agency to implement these in a way that really doesn't hurt the disability or aging communities any worse than it already will. So in terms of next steps, you have to collaborate on this. This is a really critical time to reach out with other organizations, other disability groups, other community groups, provider groups, whatever, along with your state Medicaid officials, even your federal representatives. Even though this law is passed, we would love to have Congress come back in and try to do something to limit it a little bit if they can, maybe provide some extensions. Same with your state policymakers. They can do anything to sort of steer your governor's Medicaid offices into applying these things more appropriately. That's really critical. They love, love, love to hear individual stories and individual concerns. So please share those. Relatedly, just know that there's been a lot of misinformation about who will be impacted by these Medicaid upcoming changes to Medicaid. So sharing our materials, NACDD's materials, anything else to combat that is really important. We're hoping again for more guidance from CMS, so always keep on the lookout for that. And then you're always welcome to join our Justice and Aging listserv. We're planning a webinar for next month on work requirements. As you said, we'll be updating our toolkit. And then, hopefully providing out more resources in the months ahead. So you're always welcome to join our listserv there. These are a lot, just a tidbit of the many resources we've been putting out on HR1. The toolkit is the first one. The rest of these are much more detailed descriptions of HR1. And then lastly, I'm happy to answer questions now. But I do also have my email address here. So you're always welcome to reach out to me if you have any questions. And I believe we have time for Q&A now.
We do have a few questions in the Q&A box. Not sure if I should just go ahead and read through some of these, go in order.
Yeah, that's
Jennifer
fine.
Bertrand is going to facilitate the Q&A process. Jennifer is our policy chair here at NACDD. So Jennifer, can you see the Q&A box questions?
Yes, thank you so much, Eric.
Perfect.
I love how you're always on top of everything and willing to help out whenever it's needed. Thank you, Dalila, for this this information-packed webinar about what HR1 put into place and what we can expect and the details around the work requirements and how they can impact states. And additionally, what we can do about it and this toolkit that advocates can use to help educate and inform policymakers. And preparing that letter template will be very valuable for people to individualize. So I'm hoping that people will use those excellent tools that you shared today to help these policymakers understand how it impacts their families and that they'll share their stories. Yes, we're going to get to the Q&A here. We're going to bring that up. We have a few questions here. So Ashana asked, who are the expansion states and what does that actually mean?
Yeah, that's a very good question. So there's about, I believe it's 40 states in the District of Columbia. These are states that expanded Medicaid eligibility to people below 138% of the federal poverty level who aren't getting Medicaid through a disability pathway. So this was available under the Affordable Care Act. Before that, the only way an adult could get Medicaid is if they were disabled, pregnant, or a parent of a minor child with very, very limited incomes. So it didn't matter if you had zero income pre, 2013. If you were, you'd have to be disabled and meet the definition of disability under Social Security is critical. Now, these 40 states and DC did is they said, well, if you're making less than 138% of the federal poverty level, you get Medicaid now. So it's much more aligned with the idea of Medicaid being health insurance for people who don't have much money. I can't tell you all the 40 states. I know the states that don't have it are mostly of the southern states, South Carolina, Florida, Texas is a big one, handful of others. So yeah.
Excellent. And Kay was wondering, since we're on the topic, how would it impact states that have already passed work requirements?
Yeah, that's really quite a good question too. So as I mentioned, Arkansas had work requirements, but it had to be stopped by a judge. Several other states have submitted waivers to CMS before this happened, before the law was passed, asking to implement work requirements. As of now, the only way states can continue with work requirements is if they've already gotten that approval from the federal government. If they want to continue it in a way that's not in compliance with HR1. So some states might have submitted waivers that were more generous than HR1 requirements, some more restrictive. The bottom line is by January 2027, all states should have work requirements that are consistent with HR1. So the short answer is if CMS said states can continue with their work requirements, they can continue with their work requirements. But by January, it has to be compliant with HR1.
And there was another question here in the Q&A from an anonymous participant, what happens when states try and fail? Is there a legal argument when people's due process is violated and their benefits are cut arbitrarily?
Oh, absolutely. Yeah, that is a very good question. And that's how Arkansas's work requirements under the first Trump administration ended up getting shut down by the courts, is because it was violating people's due process. It was putting them in an impossible situation. They literally have a website that people have to log into that would shut down at like 7 p.m. Or 8 p.m. at night. And so people were just in this, consistent circle of hell when they were trying to comply with the statute, with their state's rules, and they like literally could not. It was impossible to meet that. So that's why it's really important for individuals to know that, can constitutional due process rights do still exist? There should be fair hearing processes. The ADA still exists. So access to information in a way that's accessible and assistance that's accessible is still very much there. And again, that's why we want to keep engaged with advocates, self-advocates, and advocates on the ground to please elevate these issues so that we can support you or we can help you in any way we can if these due process violations occur.
Thank you, Jalila. There's another question. Folks would like to hear a little bit more about the required outreach to stakeholders. How do people know when the state is, implementing these requirements? And is there a place they should look to find out whether or not their state is asking for input?
Yeah, that's a really good question too. If you have to look for that information, your state probably isn't doing it right. If they are actually implementing it and you're not aware of it as a Medicaid beneficiary or a worker or an advocate. So that's the problem, right? Is we're concerned that states should be doing this outreach, but they won't be doing it properly. My best guess is always your state Medicaid office or your county Medicaid office, whoever is there to provide the forms when it's time for Medicaid renewals, or when during COVID, there was the public health emergency unwinding where there's some changes with Medicaid. So a lot of the similar processes about, things are changing a little bit now. Here's what's going on. Those same people should be following a similar process now, providing lots of information and things like that. But it could be difficult because you can't really prove a negative, right? If they're not doing it, then that's again really problematic.
We had another interesting question here in the chat from Stephen Cohen. He was asking about what is the relationship or responsibility of social services and VR in support of helping people to return to work in order to meet these requirements?
Yeah, that's a very great and logical question. And that's what we were asking lawmakers when they were drafting this bill, is that if we want people to work on Medicaid, wouldn't it be great to invest in social services and vocational rehab programs to help people work? And unfortunately, there's nothing in the statute that really puts, and as far as I'm aware, nothing in the statute that puts any extra funding or extra responsibility on these social service groups that can help people work as they're able. Instead, it's more of the stick versus the carrot. So instead, it's punishing people for not working as opposed to providing supports to get them to work.
Interesting. Richard Gallo in the chat, he was talking about, I believe he's from California and applied to serve on this commission, but wasn't selected. And is interested in understanding how else can people get involved to help protect their children with disabilities, with chronic health conditions, seniors and people with disabilities. If an entity such as that, if you're not on an entity such as that. And I think you mentioned some earlier.
Yeah, absolutely. And again, if you've seen one Medicaid program, you've seen one Medicaid program. So I can't tell you specifically for your state, but if you have your state DD councils, your local Medicaid offices should have resources. Area agencies on aging are very helpful. Aging groups are obviously very Medicare focused, but again, significant number of older adults are on Medicaid, so they should have a lot of resources available. All the provider groups and health condition groups, we work a lot with the autism societies and the Muscular Dystrophy Association and all these other groups have also been really helpful. So that's probably where I'd recommend first. And then looking out through the government's website where they do release information or press releases, they may have comments, opportunities for feedback where they say, 30 days, please respond to us. Here's what we're thinking about doing. That's another great way to give direct feedback to organization, to the government.
And I
There
will
was one
just say real quick, this is Jill from NACDD. I'll just say real quick, get involved with your DD council is certainly, the way that a way that I would suggest, the key way I would suggest. And if you don't know how to reach your DD council, you can go to our website, nacdd.org. We're the National Association of Councils on Developmental Disabilities. There's a drop-down menu, very easy to use to find your DD council and to reach them. So we can, I think someone just put in the chat how you can find us. There's a drop down. You can find your council, reach out to your council. If something goes wrong, reach out to us at NACDD and we'll help put you in touch. But councils are very powerful. They're very engaged. They're engaged at local, state, and federal levels. So I highly recommend that as an option.
And there was one other quick question before we get to the closing of today's webinar relative to, is using the Olmstead ruling, could that be used in like a state fair hearing situation to argue against perhaps a caregiver's Medicaid being cut or reduced or eliminated? I'm not an attorney. I don't know all of your background. What would you say about that?
I am an attorney and I have no idea. But that is a really good question. That is an argument we've been raising with policymakers, is that family caregivers play a critical role in helping people not be institutionalized. That's really the crux of it, especially when we're having a direct care workforce crisis. And as we're seeing more provider payment cuts and that crisis getting worse, whether it's sufficient for a fair hearing is a really good question. I'll happily escalate that to some of our litigation team and others who may know more. But that's definitely an argument to bring up, is our caregivers are keeping us from institutions. Why are we cutting their Medicaid and disincentivizing them from providing those caregiving services?
Very good point. Well, I've noticed the time is 4:56 p.m. And as we wrap up, I wanted to highlight a few takeaways from today's conversation. First off, work requirements and related administrative barriers pose real risks to Medicaid eligibility, continuity of coverage, and access to home and community-based services, HCBS. These policies often move quickly through state budget, waiver, or legislative processes, making early monitoring and response essential. The Justice and Aging Toolkit we talked about and Jalila shared today offers a concrete, actionable resource that DD councils and advocates nationally can use and be more informed to anticipate the risks that we foresee coming, to engage policymakers and to protect coverage for people with disabilities. We will be sharing the recording from today's webinar, along with links to Justice and Aging's Toolkit and the recording from our first NACDD community webinar shortly after the event to everyone who registered. And on behalf of NACDD, thank you again, Jalila and Justice and Aging, for sharing your expertise and the work that you do every day to help protect Medicaid and community-based services in your states or nationally. We truly appreciate your time and your engagement today, everybody who was able to step away from the busy day to day and other work and caregiving responsibilities. Jill, do you have anything to add, or shall we adjourn?
Well, I would just add, we've got 3 minutes left, so I would just add a big thank you to everyone who attended today. Really appreciate it. Keep an eye on, if you aren't already keeping an eye on our social media, go look at our social media, because as we have new things that come up, we always put them on there, new webinars, new information. Follow us on social media. We're National Association of Councils on Developmental Disabilities. If you registered for this today, then you will automatically go into a newsletter, and we will send out a newsletter to you that will update you on what's happening at NACDD and at DD councils. And your participation is vital. So if you are here today and you're not involved with your state developmental disability council, please get involved. They want to hear from you. They want to know what you want and need. And that's a great way to be involved as an advocate. Thank you for everyone for being here today. Thank you, Jalila. Fantastic.
Thank you so
Thanks,
much. I
Jennifer.
appreciate it.
Bye.
And if there's nothing else, I'll close it out.